All right, well, our next speaker, to continue the theme of pediatrics, is Dr. Jeffrey Gold, who is now an alumnus of the Virtual Medicine Conference, having spoken here last year and represented the pediatric contingency, which we've expanded this year. And he is a professor of anesthesiology and pediatrics, and a number of other topics too, psychiatry and behavioral sciences too, and director of the Pediatric Pain Management Clinic at Children's Hospital Los Angeles through the USC Keck School of Medicine. He has long and deep expertise in using a variety of technologies, including virtual reality in kids, and in particular for acute and chronic pain in children. And last year he gave a terrific talk really overviewing the evidence for using VR in kids. And this year he's going to continue that, talking about pediatric digital therapeutics versus gaming for behavioral health and pain, demystifying the risk of VR dependency with kids. And this issue of dependency comes up all the time, and I'm often asked, if sure we're not using opioids, but are people going to now become addicted to the VR headset that we're using? And I don't think so, but I think we need more information, and maybe we can start part of that discussion within the context of this broader lecture today from Jeffrey. So thank you again for being here, and we look forward to your comments. Here, this is yours.
Thank you very much. Thanks for the introduction. It's great to be here. It's a very exciting time in virtual reality and with pediatrics growing. And Kate, that was a fantastic presentation that you gave. A lot of exciting things happening. So how many of you think that there is VR dependency? Okay, so about less than 1%. So that's kind of the conclusion of my talk. And so I think we're all pretty comfortable recognizing that there isn't an idea of VR dependency, although people ask us about gaming, right? In pediatrics, it's all about gamification. I like that word because VR was really built for pediatrics, the way that I think about it, and been thinking about it since 2004. So I will be spending a little bit less time talking about the demystification of addiction to VR, but I think we all can recognize that there are issues around screen time in children, around video gaming and watching streamed content like Netflix and Hulu and etc. This came out recently in a children's hospital specific journal about the 19 innovations. And VR is one of them amongst many others, but I think it's catching on. I mean, for some of our colleagues like Dr. Walter Greenleaf, he's been pursuing this for over 40 years. He was onto something much longer than a lot of us have been thinking about it, but I do like seeing it come into the play right now. I work with a number of companies.
For kids who are hospitalized over
This is a company that's bringing
long
something to
periods of
children
time,
right now, and I wanted to
feel
share this with you in a couple of different
feel
ways.
Anxiety or depression. To get that child outside of their room and engaged back in society or in the world would be a wonderful experience for the kids, especially when they
I'm glad I'm
just
wearing a
felt
different
sort of
colored
stuck
shirt today.
in a hospital room for a long
good.
period of time.
Hard not being able to travel. Other people go to like trips.
The dialysis
I can't
unit?
do that, or we can't do that, and that's hard.
What goes on in the imagination has profound physiologic effects. So if we were to give people a euphoric virtual reality experience while they're undergoing chemotherapy or dialysis, the immersiveness of the experience could take it to such a level, we don't even know how many different applications in medicine might find it beneficial.
Walking into a hospital like this and not knowing what you're going to face is a very scary situation. So imagine that virtual reality
doing
type
procedural
environment
preparation
could be
for exposure to a
delivered,
variety of different
and they can
units.
actually start to go through what that experience
Through
might be
IV
like
placement
in
or
a
PICC
first-person
line or other
experience.
invasive
It's
procedures.
powerful and transformative in the sense that you have the knowledge, you have the information, and you will then be more prepared for being able to go through that procedure than you were when somebody just told you your diagnosis and then went on to tell you the treatment.
Surgery is a 360 experience. It's an experience that, as we do with anything else in life, we experience
Using it for
things
real-time
around us.
surgical
Decades
intervention.
ago, a doctor could come in, you can have a visiting professor coach you in how to do the operation better. That's almost virtually impossible now, so we'll use virtual reality to bring those professors into the operating room along with us so they can see what we're doing. They can have the same information available to them. This is really the future classroom. in terms of being able to bring people into
You can
the
layer
operating
in
room
VR
experience
goggles,
what we're
diagnostics,
experiencing,
images,
to
surgical
perform
site,
good
other
surgery
staff.
and to do it safely with good outcomes.
I think what gets missed often is the child's mindset and this concept of mindfulness. Mindfulness can be a very powerful healing tool for kids and for families to be able to engage the brain or the mind to be able to exert healing powers on the person's body.
If one can think themselves ill, the question obviously comes up, can one think themselves well?
Part of being in the hospital is being exposed to everybody else's care. Sometimes there's critical events, a kid crashes on the unit. With virtual reality, you can transport them into another space. When we're able to engage the kid's mind through relaxation, mindfulness practice, guided imagery, then it can have a very big influence to control body and to impact soul.
So this is only in pediatrics, and it's something I think about often, that again, it was designed for pediatrics. Gamification and playing is really engaging for children. When adults are treating children, it's very hard to connect with them, even pediatricians and other pediatric subspecialists. So this VR experience, whether it's knowledge-based, education, exploration, procedural preparation, or in pain management, like I'm going to talk about today, it's a very powerful tool. So VR has been applied in a variety of behavioral health contexts, and some of the other presenters, like Dr. Rizzo, alluded to some of those, and I listed them here. One of my favorite VR environments back in the day was the virtual crack house. I always think that's kind of funny that we had that in substance abuse. But as the psychiatrist mentioned earlier, there's cues and triggers and ways to sort of manage those. So in the virtual environment, it's perfect for that. We also saw Dr. Rizzo earlier. He didn't present today, but he developed this wonderful diagnostic for ADHD using a classroom that was able, you can manipulate it and change the objects and change the noise, change the participants in the classroom, deal with inattentiveness and hyperactivity, and measure that in a very meaningful way, in an ecologically sound way, not just paper and pencil tasks, but through video gaming. This was a really early introduction by Dr. Rizzo. It's been very powerful, and you can purchase it off the shelf. Again, much more engaging for children. We saw early education in children with autism around safely crossing the street. We saw this kind of head-mounted display where they could be educated about the risks of crossing the street without looking both ways, etc. Much more engaging than just trying to speak to the child and do that. It's an intervention. It's short, limited. It's not long-term. You're delivering information. You're not asking children to enter into head-mounted displays or goggles for hours on end. Again, addressing that issue of dependency. We talked briefly about panic disorder and other exposure-based interventions for anxiety and phobias. Public speaking, that was alluded to earlier also. People would rather be in the pine box than delivering the eulogy as the ongoing statement of public speaking, right? That's number 2. So we really recognize the need for that, and Dr. Rizzo presented a lot of the new interventions and smartphone interventions, delivering fear and anxiety around public speaking. Fear of heights, also something that VR has been used for effectively in the behavioral health realm. We see fear of flying. There was some data earlier on PTSD and the use of VR for that. This was really caught my interest recently. Dr. Navarro Haro and Hunter Hoffman, who's a colleague of mine at the University of Washington, did this wonderful work in DBT and augmenting DBT training with the use of VR in the behavioral health realm. It was very powerful. They had good results. It's the first study of its kind. They enrolled about 42 adults in dialectical behavior therapy to be, again, delivered via the head-mounted display. And the results were good in both groups about reducing anxiety, but what they found was in the VR-delivered dialectic behavioral therapy is that it reduced the number of dropouts that we saw in the participants. So we were able to engage the patients for a longer period of time to deliver the necessary treatment in the context of that group. So again, that is a great application of behavioral health in VR. Here's a kid going through pediatric rehabilitation around burn. We see this again with Hoffman and Patterson at the University of Washington, where they're able to use VR to augment narcotics or opioids for range of motion, bandage change, wound care, etc. All right, so let's talk about pain a little bit. This is a new topic. It's been around just for a few years, this idea of acute to chronic. Okay, so in my world, we're talking about the narcotic or the opioid concern. So if we can target children earlier around acute pain and chronic pain problems, we have a chance at reducing an overall explosion or mushrooming of narcotic or opioid abuse later in adulthood. So that's the way I like to look about it. So acute to chronic, it makes you think about the biopsychosocial model. You have to be considering all things. This is not tissue damage, but it is many of these functional parts that you see that we're not going to go over today, and you will not be tested on today. But these are very important parts of understanding acute pain and also chronic pain. You've seen a lot of the statistics about the cost in the adults, $635 billion each year in medical treatment and lost productivity. The bottom information is new for adolescents, about $19.5 billion lost school days and et cetera, and about for the USA and $9.5 billion for the UK annually. Those are daunting costs. So it's not just an epidemic in adults, we see it in children too. The biopsychosocial spiral I've discussed before, it's all regulated around the idea of stress. And there's a tremendous literature on stress. There's a tremendous literature on the psychoneuroimmunology around stress. So this is a very well-documented phenomenon, and these are the types of things that we target when we're working with our kids, both acutely and chronically. And this is just a nice visual, because I want people to think about how do emotions, cognitions, and pain interact both positively and negatively. Why is this relevant in VR? Because we know the least understood organ in the body is the brain. We recognize that the brain is not well studied, even though we have sophisticated imaging techniques like DTI and functional MRI, but it's still just a spit wad on the elephant, right? We're just starting to learn what all those folds mean and what all the neurocircuitry is, but we do recognize the influence and the power of the brain on our body. And integrating that with both the messages we send ourselves cognitively and the emotions that we experience have both positive and negative impact on pain. I like to show this slide because so many people want to fix everything, right? Especially in the medical world, we need to fix it. And sometimes with the patients that we treat at Children's Hospital, we're not fixing as much as we're trying to promote wellness and health. We're trying to get that child up and functioning. Right? So it's not so much about a cure as it is about health and wellness. And it's something that we say to our patients often. We're trying to promote their overall health and wellness. Anybody ever seen this head mount before? Okay, my first head mount cost like $50,000, right? Now they're like $399 for a new machine and a new technology. This was a study by Hunter Hoffman, that last one. So this is where the state of the science is right now. If you went on to PubMed, which I went on about 5 minutes ago to update the slide before we rolled them, okay? Virtual reality has almost 10,000 articles, just plain old virtual reality. And then you break it down. Behavioral health's got over 600. Virtual reality adult pain has about 180, et cetera, et cetera. And chronic pain has about 87. Okay? So you had a brilliant speaker earlier, Diane Gorman, speaking about chronic pain and her work in that area. This is a very important, new, innovative area, tackling chronic pain, and yet very little has been published in that space, but it's a very important direction. Here's our first study at the Children's Hospital Los Angeles, which was a randomized control trial in 4 conditions, as it's stated here. There's my $50,000 headset, which probably couldn't really do very much. And then we used a cartoon distraction, a flat screen with the same environment, and then the head-mounted display. I don't know if Rebecca Allen is here today. Hi, Rebecca. So she is the OG VR video producer. This was the only thing available at that time in the early 2000s for pediatrics, was this, she called Bush Soul, where you could interact with the environment and you could move towards plant life and dance with the plant life, and there was music, and it was very psychedelic in a very interesting kind of fun way. But we were able to use this because this was off the shelf. We had nothing else back in the early 2000s. And we were able to demonstrate, I guess it wasn't here. It got lost. We were able to demonstrate that across the 4 conditions that the kids in the head-mounted display did better than the kids just on flat screen. And if you look closely, we used that wall pass because there were a lot of critics who said, well, you're just putting blinders on the kid and she can't see the needle coming, so that's why she's having less pain or less anxiety. So we put that pass wall in so every child, no matter what condition you were in, had their vision occluded. So that was an important methodological consideration. Then we did a study in radiology around IV placement with a new game that was off the shelf called Street Luge, which had more gamification to it, where you were able to earn points and race against time and et cetera. And we were measuring pain and anxiety and some of the usual outcomes, and we were able to demonstrate that kids in the VR did not have a significant increase in pain from pre to post, but that kids in the control condition did have almost a 4-fold pain intensity increase as a function of the IV placement. So how many of you in the room really love to have a needle inserted into your appendage for blood or for IV? Raise your hands. Hi, let me count you. Right, so that's the issue. It's still scary. It still hurts. I'm like this, I don't know what I want to call myself exactly, but I'm this breed of VR investigator who still wants to do acute procedural pain management. A lot of presenters today are moving the needle to really sophisticated work, which I commend and I think is fantastic in pediatrics. Between chronic and acute, I'm going to still swim in the acute world because we need to deal with this, right? If you can have a child have a positive needle experience and they come in 7 or 10 times a month to your clinic or your hospital and they're not afraid to come in and they're not developing stress symptoms like PTSD as a function of being stuck so many times, that's a win, right? That's a win for us at the hospital. And we don't want them later to be afraid of getting medical tests. So we're really functioning and focusing on trying to maintain that fear anxiety now with these types of interventions. You also see it in dental pain. I won't review all of this, but the use of VR in dental pain, and that shows decrease around fluoride treatments and et cetera. We've also seen it in adults with a really nice study where they did a cross-mouth design, which was kind of cool. Half the mouth was VR, half the mouth was not VR, and they did measures. That was very cool, and we were showing that the adults in VR were reporting less self-reported pain in VR. And so there's been a number of places where we've seen VR proposed for acute pain. So recently, we've been moving into new technologies, as everybody knows, and we've been able to do some of these studies, now also focusing on the Oculus Go, and being able to integrate many more types of environments into our hospital. So we have collaborations with Applied VR and SC, and this is a rendering of Children's Hospital. So we're collaborating and using a game called Bear Blast that we're using, which we've been able to test and publish on over the last couple of years. Dr. Marr, my collaborators here in the audience, and a number of the other VR team members are here in the pictures. And so we've been able to move our forward, continuing to look at painful needle procedures. What we've seen in our historical literature is burn care, a nice study in sickle cell pain with virtual reality with Kind VR. They have done a number of really great studies in that area, routine procedures, and then also in chronic pain more recently. Okay, so this is some of the routine procedures we're tackling now. We've recently started to grow. So we weren't just blood draw and IV, but now we're also went to cast removal. We're following the venous access team. We're participating in transnasal endoscopy in a non-sedated way, which is a new direction for some of the ENTs to go, which is exciting, being able to use that during those procedures. We were able to, this is for IV placement. So this is our current cohort. This is fresh off the press and not published yet, so please don't get too excited. But this is going to be going out for publication soon. You can see the breakdown of our patient population, where we collected our VR data at a variety of different IV start locations like the infusion center, radiology, and also along the vascular access team. We have a pretty even split between boys and girls in our population. And we're starting to see both patient and caregiver, like we have previously, reports of anxiety and pain less in the VR condition than, again, in the control condition. So those are reported, I think, here. So you can see that there's a significant difference between those two groups on the FACES pain scale and also on the anxiety visual analog scale. So we're starting to detect these differences during IV starts, similarly to how we found them in phlebotomy. And this is on the FACES pain scale, so that's well shown with a standardized beta negative 0.44. This is the recent study we published in a Journal of Pediatric Psychology, looking at, again, blood draw. It was very similar. How many of you think this child looks very happy? I mean, again, it's just a picture tells 1,000 words here. Very unhappy about his procedure. You can't see the facial grimaces or whatnot with this particular patient, but there's that sense of calm. The procedure goes smoother. The caregiver is happier. The patient's happier. So it's a smoother procedure. And even though we thought maybe it would slow down the throughput, it actually can speed up the throughput once it's on a clinical service versus a research site, because that obviously takes a little bit longer. Bear Blast is the game that we've been testing and using via applied VR. And we were able to demonstrate here, again, decreases in pain scores between the two groups amongst the caregivers. So the caregivers are reporting that they feel like their kids are doing better. And then we're also seeing both in the patient and in the caregiver significant differences between the VR and the control group on measures of anxiety. This was a really interesting finding, which was anxiety sensitivity. So when you're sitting getting your blood drawn, you start to get a little worked up, a little physiology, a little heart rate, a little high blood pressure. You know, it's called anxiety sensitivity. Is a sense of physiological arousal. So what we found here was that the anxiety sensitivity, as that went up, the anxiety also went up in our control group. And we see this interaction that as the anxiety was low in the VR group, that the anxiety sensitivity also went down. So there's a relationship here between physiological arousal and the self-reporting of anxiety. And then we have patient and caregiver feedback, and we also have phlebotomist feedback about their satisfaction with the procedure and how well they felt it went. We've had some press, which is great. I mean, it's just good to get this out there. I had a lovely interview with a woman from the New York Times this morning and yesterday. So we're getting out there into the press. People are starting to understand what it is that we're doing and what we're offering. Our phlebotomy was so excited and interested in our findings that they went and purchased systems for their blood draw area. So now the kids have access to it. They've got placards that are hanging that says, if you want VR, you may request it. So we're moving from a research model into a clinical service line, which is fantastic. But I believe that has to be data-driven. You know, if you're going to tell me you have a really outstanding product, show me the data. Let's look at it, and let's see if it makes sense for the population that we're interested in. VR is not good for everything. Okay? This is a child who's going through VCUG, right? So she's getting catheterized, and you can see her starting to breathe heavy. You can see her anxious. She starts to move around a little bit, and then ultimately she doesn't want to use it anymore. Okay? So our team has been talking, well, why is that? Okay? It's a very personal procedure, right? This child's learned her whole life, you know, don't let anybody touch you in your genital, your private area. Now she's got something over her face. She's being catheterized, a bunch of people in the room, okay? Maybe this isn't a great procedure to use virtual reality. Okay? So we need to look at what that looks like and then talk to the medical team and say, what happened? What went wrong? Well, they said, this is the best one she's ever done. We're like, what? Well, she looked really horrible. She goes, yeah, but she was still, and we were able to do our procedure because the VR got her through the hard part, maybe that first couple of minutes. So they might want to take it off and see what's happening, and then once the catheterization is done and successful, then she wanted to put it back on and continue playing. So it's not like it's not one size fits all, as Kate said. Okay? But we have to, again, test, control, experiment, pilot, and learn from our patients, and learn from their families, and learn from our healthcare providers what's the correct match. So VR and digital and behavioral health. So what is it good for anyway, quite honestly? So we have so much room for growth right now. Individual talk therapy, patients could be using VR in that particular way with their therapist, learning mindfulness. We could use it for education around group therapy, family therapy, biofeedback. I love this idea of feedback loops and rewarding systems back to the patient. Home and school-based for telemedicine, using smartphones. Again, Kate talked about smartphones today and how useful those can be. Telebehavioral health. And again, VR could be good for our healthcare providers also, right? Behavioral health for our healthcare providers. If our healthcare providers are doing well, then ostensibly they're delivering better healthcare to their patients at the bedside. So we need to be focused not just on the patient, but also thinking about our healthcare system at large. Okay, so some of the future considerations. How can we integrate scientifically informed, in-clinic, VR-based digital health interventions or solutions that can translate and be portable into the community or home or in the school? Okay, big question, something I wrestle with all the time. But we need to be thinking about how we can augment our healthcare with VR and roll it out into the community. Reimbursement, this is huge. I've been talking about this for far too long. But wouldn't it be great if when a attending dropped a request for phlebotomy and paired with it was a request for VR, and then VR was reimbursed? Wouldn't be horrible. That'd be incredible. And that would be a better outcome for that child. So something for us to think about and have to work with the insurance brokers to make that happen. How do we incorporate and customize intrinsic and extrinsic rewards and feedback? The feedback part is really powerful. How a body's physiology or EEGs or breath can manipulate the environment in which we're looking into. That's really important. And how that then drives and customizes where that patient goes or travels in their VR environment or experience. How many people have heard of multiplayer in VR? Okay, so next year, everybody's going to raise their hand because this is super important, right? Right now, it's very egocentric. Put this thing on me and I'm all alone, right? And I'm doing my thing. For a kid who's got a caregiver, mom, dad, auntie, grandmother, grandfather, like they could join in, right? So I'm working with developers right now to create multiplayer VR experiences, right? People say the AR might be a little bit more interactive because you're in your environment and et cetera, and a little bit less egocentric. But this would be a really great advent for digital solutions, right? So VR, although people think VR might be going away and move more towards AR or MR, mixed reality, I think VR still has its place specifically in painful acute procedures, as we've been talking about. And introducing multiplayer is going to be pretty significant and probably pretty cool. I think the parents would really dig that. VR for chronic pain, of course, the opioid crisis it's on everybody's radar, so we're always thinking about that. I'm expanding VR into the hospital for pain blocks, transnasal endoscopy, as we've already started, the VCUG program, trying to customize it, make it correct. If we can have a good experience, that'd be wonderful. Around mask induction, I think there's an anesthesiologist in the audience. He and I emailed a few times about mask induction in VR. VR for mental wellness, we call that at our hospital. And then it really, from an outcome standpoint, I can't argue this stated enough. We need to be collecting not only self-report and behavioral measures, but we need to be looking at EEG and other physiological data. We need to be looking at biosensors. Anything that's going to be objectively based to support the work that we're doing is going to be critical. Because otherwise, it's just going to be another cool, sexy, interesting, fascinating, innovative idea. No data, no bueno. It needs to have data to move this agenda forward. We're having a hackathon at Children's Hospital Los Angeles. I have been fortunate enough over the last 2 years to partner with Disney Junior, and we helped them to develop a really cool program that we've been piloting at our hospital just from a end user part, not a research part, but it's an end user experience, and we're very excited about that, and hopefully they'll be making an announcement about that sometime in the near future. But being able to partner with large companies like that who employ really cool and really creative people, a lot of fun, right? Never discourage you from collaborating. The hackathon, as you can see, is here. It's in April 12th to 14th. It's trying to, again, our accelerator or our innovations lab is trying to pull people together to create new pediatric solutions, again, in the gamification manner. So we're really excited about that, and we hope that you'll be participating. Thanks to a lot of collaborators. There's been some founders in the community who've been super excited to get behind our pediatric work. Applied, Tower Cancer, Epicenter VR, And I can't thank the patients enough and the VR staff that works in my lab. I can't thank them enough because we work tirelessly all over the hospital to collect data, because we all know it takes a long time to collect data, meaningful data, clean data, in a chaotic environment like a children's hospital. So thank you for your time. I appreciate the invitation, and I look forward to future conversations. And I'm facilitating a pediatric group tomorrow, so hopefully you'll all be there asking some really great questions. Thank you.